And I will be very happy to introduce to you a new concept in the refractive surgery. I myself have been practicing refractive surgery since the year 1992. And of course, I know that the hall is full of many expert refractive surgeons, and we know we got some time to change our paradigm or our beliefs in the concepts and the ideas of refractive surgery. And this is the time to introduce a new belief or a new design of our patients. So the legacy of refractive surgery, or how we fashion the lens to be printed on the cornea, comes out from the data that we have from the topographers and the aberrometers. And this is the concept that we live in, to print a lens on the cornea. And now it's a time to debate why it is not very accurate, because we have a lot of fallacies. Although aberrometers, for example, gave us a lot of information, yet they have their own fallacies, like, for example, the crossovers that we might face. Okay, the crossovers that we might face by a lot of lenslets, when you have a lot of lenslet arrays to receive the outgoing retinal picture. Again, the aberrometers are limited, and the wavefront size are limited by the size of the pupil. So when you have a small pupil, the extra data are extrapolated, and then the results are not so accurate. And then our reconstruction of images coming from the aberrometers might suffer some inaccuracy due to the polynomial grade interdependence that coming from our knowledge of the Zernike shapes. Yet I have to say that the complex corneas are our main enemy in refractive surgery. And against all beliefs that complex corneas are rare, no. According to the statistics, the complex corneas are not only those of the ectatic corneas that we meet with less infrequency, but every irregular astigmatism, every hyperopia, every mixed astigmatism, and even high astigmatism, but a regular one, could be an irregular cornea, because it's a combination of some irregularities in the cornea, a high K read, a high angle kappa, or it might be with, in some cases, scars, opacity, pterygium. So if we calculate these in numbers, it might be 2/3 of the practice of a high, excellent refractive surgery center, or for the average refractive surgeon, it could form like 1/4 of his practice. So we're talking about a common phenomena, a complex cornea, not a rare phenomenon. So the idea of the ideal shape that comes from this novel technology of the Ivis depends on a multitude of machines that, first of all, depends on a high precision tomographer, which is called the Precisio, that takes with a high precision in 1 second the tomography, a detailed tomography of the cornea. And then it also relates that to what's called the P matrix, which defines the ideal pupil size, and transfer this into the cloud to play with a SIPTA, high advanced software that can tailor the treatment design according to your needs and be executed by a very speedy excimer laser with the smallest and tiniest spot size in the market now. So regarding the complex cornea, this Precisio, which is a high-definition tomographer, can define to you what we have in mind, like the elevation maps, anterior, posterior, and epithelium one, and also the posterior elevation maps and the total perimetry maps. But not only this, it can ray trace the rays of light when it passes through this cornea, this complex cornea, into different layers of the cornea to define the lens that will be formed by the anterior surface of the cornea, the epithelium, which here plays a major role also of changing the refractive error of the cornea, and of course the posterior surface. And the summation of these refractive media of the cornea by a very neat analysis will be gathered into the ideal shape. And this is the form of the ideal shape or the new concept that's going to be introduced. The ideal shape is that shape that will match the ideal pupil, the pupil that you need in real life. And again, it is with the minimal invasions that I will show to you, because it will use a small refractive zone, and again, a tailored and fully customized a connecting zone, or what we called in the past a transition zone. And here lies the genius of this design. Let me first tell you that the genius of Michelangelo was the one who made a revolution in the Renaissance in the art and defining the ideal shape. The genius of him is that he could imagine a marvelous shape or a marvelous statue like the one of the David out of a block of marble, and by taking out the excess, exactly as his imagination. This is again a change of our paradigm, or a revolution of our refractive surgery concepts of taking the excess of the cornea to define the ideal shape. Again, by carving the cornea and taking out the excess. And if you think of it, it is a minimally invasive task you do on a cornea, taking the excess to define the ideal shape. By the way, the ideal shape could be totally irregular on the cornea to match the irregularity of the posterior surface, and here it comes the beauty to make every single point that falls on the cornea falls on the fovea. And this is what we define by the ideal shape, to define the best quality of vision ever. Again, this will match what is ideal pupil, and the ideal pupil is defined by the P matrix. It is again the pupil that can help the patient. Every one of us has his ideal pupil, depends on his pupil dynamics and again his profession, by mimicking different lighting condition and selecting what's called the ideal shape or the ideal pupil. And again, we have to return back to our basic optical teaching that according to the Stills-Crawford effect, 80% of the photons that forms the vision, the best vision that we have on the fovea, comes from the central 2 millimeters of the pupil. So if you carve a refraction zone on these 2 millimeters of the pupil and then design your connecting zone, you will reach to a marvelous results with a minimal invasion of the cornea. Again, this is the ideal shape, as I told you, is to carve a small refractive zone and then a fully customized connecting zone, as you see, to re-tilt the cornea, because any irregular cornea or complex cornea is a kind of tilting the cornea, as we're going to see now, and here it becomes tilted again without having to do an excimer laser on the periphery as other platforms do. Let me introduce to you the case introduction that we're going to have a remote surgery. First of all, the remote surgery is a new concept also of this device that I will operate now on a patient that is lying, he will be lying on his excimer laser bed in Bari, Italy. I mean, maybe like 5,000 or 6,000 kilometers from here. And this is not the first time. The first time was made by Professor Giovanni Alisio, who will be on the other side now in Bari. Professor Giovanni Alisio is a professor of ophthalmology, Bari University, and a leader of refractive surgery. And he made a lot of works on Ivis technology and made the first remote surgery, I think 1 year ago. And he made again one with us from Dubai in last April. And this is for the first time maybe in India to have this remote surgery. The case will be a lady. She's lying now on the excimer laser bed in Bari. She's 30-year-old and she has a mild ectatic cornea, meaningly or is an early keratoconus. Best corrected visual acuity of 2025 was minus 1.25 and minus half diopter of astigmatism, and the uncorrected vision is 20/50. Let us see the data acquisition by Precisio, which is the anterior map. We see the pumpy cornea in the anterior map that matches the stromal one, and of course the posterior map has a more pumpy cornea because keratoconus starts from the posterior surface. And this is the thickness map. Again, you can see clearly that the epithelium is thinned out over the ectatic area on the anterior surface of the cornea and on the ectatic area of the stromal side. And this is the ray tracing of her. You can see clearly that here there is an epithelium, oh, now the patient is there. So can't we see the planning? Just quick. Yes, this is the epithelium. This is the epithelium lens, which is about 1.5 diopter, that mitigate the stromal pumpy part. And this is the ray tracing map through the hair anterior, the anterior sliences in the cornea, which is the anterior map, the posterior map, and the total corneal map. And this makes, again, the difference on the posterior surface of the cornea. And if you see the point spread function of her, there is a tilting of her cornea because the center of the vision is not in the pupil center. And this we are going to make by simply carving the fully designed one by the Ivis technology. And this is the planning. The planning, we're going to have a 5mm optical zone that will take off 34 microns only and of the stroma to make her cornea like around 42 diopters in the center. And if you see down there, there is the a change in the angle, which is 0.2 in the x-axis, which will in the y-axis, I'm sorry, which will take the pencil of light or the line of sight to the center of the cornea without having to carve anything on the periphery of the cornea, with a designed connecting zone of 8mm and a minimal collecting zone in some parts of 7mm. So we have here a fully customized connecting zone. This will be followed by cross-linking. And again, we have online cross-linking incorporated into the same excimer laser machine. This cross-linking will be totally customized according to the thinning gradient in the stroma. This is the thinning gradient of the stroma. And you see that clearly that there is a central part of the stroma which is ectatic and thin. So the power that will be delivered by the cross-linker at the end of the operation will be again fully customized to deliver the maximum energy at the thinnest point and then a variable energy to the transition point, and it will be varying from 2.9 joule to 2.7 joule in 8mm zone. Fully customized, fully tracked in X, Y, Z axes. And this will end up with, as an expected, with these elevation maps to bring the whole cornea, as you see, in a marvelous pattern, a fully regular way to correct for the anterior, posterior, and epithelial lenses, and to bring the quality of vision to this kind of quality of vision. Will be fully executed remotely by the 5G technology with a latency of less than 150 milliseconds. And I leave the microphone to the inventor and the CEO of Ivis, Mr. Giuseppe Lepoletto, to explain more about the laser machine.
So just a few words while Professor Shafik will start the surgery. The technology basically that we use, we presented a project to the European community to allow in next future remote controlled surgery. Because remote controlled surgery will equalize the chance of success of the patient to the patient of New York, as well to the patient in Nairobi. And this basically will save a lot of money. Now, basically, the system, as you see, Professor Shafik will have here, basically the laptop, which is reproduce exactly what basically the computer is showing the live surgery, and through this 3D monitor, he can look really at the live surgery, while basically the joystick that he will use will allow basically to perform the surgery.
So what I'm going to do now is to confirm the treatment and to ask the assistant on the other side to align the patient, and then with the move of the joystick, the patient will be automatically placed. And by the way, there is a checklist which is fully automatic by the laser machine to go through the alignment, and then the alignment will be an XY axis, and then it will change the lighting. Shall we press? Yes, sure. Okay. Starting. I will press start now. Yes. Okay. Yes, the manual position, which takes the patient under the machine. Yeah. then the machine will take automatic everything. And then the most important thing, it adjust the lighting condition to mimic the exact pupil size that we had the data acquisition with the precise tomographer, which is called the Precisio. This will bring every single registration mark, the X, Y, Z, angle, kappa, whatever you imagine, in the exact position to execute this fine form of ablation profile. And then the machine will ask you to connect what is the cone, which will take all the plume because it will approximate to the cornea. After drying of the cornea, I will press from here the button to execute the treatment after taking care that all the checklists are signed with a green sign. So we have passed from the positioning to the alignment to the application of the dome, which is the cone, to the pupil control, which brings the pupil to the exact size, to the iris control, which is an iris pattern registration, and then the registration, the full registration of the eye. And then when it is ready, I can press on the button and execute the treatment. Yeah, so now I will press the button, which is like pressing the pedal in the operating theater, like now. Okay, I'm keeping pressing on the.
And now the laser speed will change from a few hertz up to 2 kilohertz to grant constant fluency in cornea, basically to minimize any kind of thermal issue.
You see now that the laser will take variable ablation speed because it will vary from the small ablation zones to the connecting zones. And of course, the speed of ablation with the epithelium is different from the stroma. And when it ends, we will execute automatically the cross-linking. And as I told you, the cross-linking again is tracked by the same parameters. So the parameters will allow the ultraviolet rays of the cross-linker, which is online on the same machine. And then done. So now the assistant will remove the cone and will start the soaking. The soaking, again, it will be fully controlled. Okay. They're starting the soaking.
Yeah.
While it's a soaking, the regular soaking of riboflavin in 7 minutes, we can discuss some cases just to fill the time with some beautiful examples, pre and post.
During the execution of the cross-linking, the energy which will be radiated will be less than 3.2 millijoule.
So I will start the cross-linking time. That will be done after finishing the soaking time automatically. The soaking time now is like 7 minutes. 7 minutes, we have passed a few seconds of them. So, to fill the time, to fill these 7 minutes until the ultraviolet power starts, did you explain the machine? I mean,
I will just give some information on the technology. The laser is a 2 kilohertz system. We have a specific patent which allows us to double the speed of the laser head. The reason to increase up to 2 kilohertz because we have a well-defined optical spot which reduces the spot size at 3.50 micron of spot size at half full width. This allows an energy radiation of below 0.1 millijoule per each single spot. Another one very relevant patent is that, as you saw, basically the speed is not always 2 kilohertz, but changes from a few hertz up to 2 kilohertz to grant a constant fluence per unit of time in cornea. and this to create an extremely smooth surface. We have also this basically dynamic arm, which is it's under the eye in order to control the flow of the air, to basically control the plume effect. And overall, even more important is that inside of the system, we have a cross-linking device which allows to customize the cross-linking immediately after the surgery. Customizing the cross-linking, as Professor Shafik said, not really according to the peak of the refraction, but controlling, you know, that basically the ectatic deformation are caused by a slippage of the fibers, and we do measure the gradient of the stroma to exactly deliver a customized energy according to the level of gradient to minimize the irradiation. If you want to show some cases.
Yeah. Just to show you some pre- and post-operative cases of this novel technology. It's not just meant for the irregular cornea, even for the regular ones, but some challenging cases. Like this is a straightforward minus 8.75 minus almost minus 9. And as you see, this is the anterior, stromal, and posterior preoperative elevation maps. We see the cornea is totally irregular. So you acquire the ray tracing of the cornea, and again, nothing is abnormal. But the beauty in it is that you have an ablation plan that only takes out 108 millimeter from the center, and then tailoring the optical zone to 7.7. And here you can do such a kind of moderate to high myopia, transepithelial one. Of course, you can use the mitomycin C, and you were gonna terminate with a post-operative. These are true ones, not unexpected ones. These are the post-operative elevation maps and the post-operative ray tracing maps that show that the power of the cornea is totally uniform, and the ablation and the patient has achieved in such condition 20/20 vision, or 20/25 vision, I'm sorry, uncorrected one. Another challenging case is in a post-vitrectomy eye. And you know that there are many challenges in those cases, especially that this eye was implanted with an IOL after vitrectomy. So you can't do a flap because you can't press on the eye with a microkeratome, whether it is mechanical or a femtosecond one by docking, but you seek again to have the maximum vision for such kinds of eyes, especially if you know the type of the lens, but you fully designed by the refraction acquired by the ray tracing. And again, these are the readings, the ray tracing power maps from this cornea, and in such condition, the calculation of the refraction will be done by the ray tracing and the ablation profile. In such case, you're gonna take 50 or already taken 54 microns with a refractive zone of 5 millimeter and an 8.1 connecting zone at the max and 7.2 at the minimum. Again, the connecting zone is not equal, and these are the post-operative elevation map for such a kind of regular, difficult cases. And it ends up with a 20 to 32 uncorrected visual acuity, something which is not very bad in such a very difficult condition in which you can't difficultly calculate the refraction and the proper ablation, and again, without touching the minimally invasive, without having to elevate a flap.
Professor Shafik, can you sum it up? Because we have the next session also ready.
Okay. Yeah,
And
we can stop
I
at
think
any time.
what we just saw is probably going to be how refractive surgery is going to happen in many, many technologies, where, you know, you just saw Shafik, Dr. Shafik sitting here and operating on a patient which happened in Italy. And so that, you know, the planning can be done remotely. I think there is a lot of scope for every technology, whether it's lenticules, lasers, and I think congratulate all the surgeons and the company for bringing this concept up very beautifully. We move on to the next session.
A quick comment that after we finishing, it's 1 minute to finish the soaking,
Okay.
and after that, the ultraviolet rays will go fully customized to cross-link this cornea. So if you allow it just less than 1 minute, we will show the ultraviolet light, and that's it. And that's it. I mean, can you switch again to the operating theater in Italy, please? Yes. So it is the soak-in time that is finished. 30 seconds to finish the soak-in time. I just gonna demonstrate how, with a click of a button or automatically, the ultraviolet will replace the infrared. The infrared of the excimer laser will be replaced by the ultraviolet of the crosslinker, and that's it. It's the usual thing, and you terminate by applying a contact lens, and that's it.
Wonderful. And for people who were outside, this is a patient in live happening in Italy.
Yeah. And as you may see now, the cross-linking is going to start, and you will see that the eye tracker will track the movement of the eye because the energy is radiated according to the corneal gradient.
So thank you, Professor Alessio, Giovanni Alessio, and this is a cross-linking. And thank you again for watching this. This is really marking a history of remote refractive surgery, a transcontinental one. We are operating from Asia to a patient lying in Europe, in Italy. Thank you. And thank you, Professor Shetty, for allowing us such kind, beautiful demonstration.
Thank you, and wish we see more of these kind of technologies. Thank you all. Thank you.